Hello, I'm Joseph, and me and my partner today are doing our kinesiology project on the shoulder joint. The shoulder joint, otherwise known as the glenohumeral joint, is a synovial ball and socket joint between the scapula and the humerus. It is the major joint connecting the upper limb to the trunk. The shoulder joint is the most mobile, yet least stable joint in the human body. In addition, it is an example of a multiplanar triaxial joint. This synovial joint allows forward and backwards movement in the sagittal plane. Furthermore, it also allows lateral movement in the frontal plane and internal and external rotation in the transverse plane. Shoulder anatomy. Synovial joints are the most common type of joints in the body and allow for the greatest range of movement. The following are characteristics of synovial joints. 1. A joint cavity. A joint cavity is the space between articulating bones that is lined with the synovial membrane. The joint capsule surrounding the joint cavity provides support for the delicate synovial membrane where it is not in contact with bone. Second, the synovial membrane lining. This secretes synovial fluid which lubricates and nourishes the joint. Third, articular cartilage. These cover the ends of bones that articulate with each other. It consists of hyaline cartilage lubricated with synovial fluid. It is very slick and smooth to reduce friction in the joint. I will now be talking about the articulating surfaces of the shoulder joint. The shoulder joint is formed by the articulation of the head of the humerus with the glenoid cavity, or fossa, of the scapula. This gives rise to the scientific name for the shoulder joint, the glenohumeral joint. Both the articulating surfaces are covered with hyaline cartilage, which is typical for a synovial type joint. The head of the humerus is much larger than the glenoid fossa, giving the joint inherent instability. To reduce the disproportion in surfaces, the glenoid fossa is deepened by a fibrocartilage rim called the glenoid labrum. This is pictured here. Now we will talk about the joint capsule and bursae. The joint capsule is a fibrous sheath which encloses the structures of the joint. It extends from the anatomical neck of the humerus to the border of the glenoid fossa. The joint capsule is lax, permitting greater mobility, particularly abduction. The joint capsule's strength decreases with age, so the older a person is, the weaker their joint capsule becomes. The muscle of the rotator cuff acts to reinforce the joint capsule superiorly, posteriorly, and anteriorly because the joint capsule provides little support to the glenohumeral joint without the reinforcement of ligaments and the surrounding musculature. The synovial membrane lines the inner surface of the joint capsule and produces synovial fluid to reduce friction between the articular surfaces. To reduce friction in the shoulder joint, several synovial bursae are present. A bursa is a synovial fluid-filled sac, which acts as a cushion between tendons and other joint structures. The bursae that are important clinically are the subacromial and the subscapular. Let's begin with the subacromial. Located inferiorly to the deltoid and acromion, and superiorly to the supraspinatus tendon and the joint capsule. It supports the deltoid and supraspinatus muscles. Inflammation of this bursa is the cause of several shoulder problems. Subscapular. Located between the subscapularis tendon and the scapula, it reduces wear and tear on the tendon during movement at the shoulder joint. Both are pictured below. Now let's talk about muscles. Since the shoulder joint is very mobile, there are many muscles that surround the joint, enabling its wide range of motion. Muscles are vital to the shoulder joint because they help support and rotate the shoulder in several directions and planes. The abductors of the shoulder include the deltoid and supraspinatus muscles, while the pectoralis major acts as an adductor. The anterior portion of the deltoid is also a flexor. The subscapularis, teres major, latissimus dorsi, pectoralis major are internal rotators, while the teres minor and infraspinatus are external rotators. In addition, the triceps branchi, teres major, posterior portion of the deltoid, and the latissimus dorsi are all extensors. Rotator cuff muscles are muscles that surround the shoulder joint, attaching to the tubercles of the humerus, while also fusing with the joint capsule. The resting tone of these muscles act to pull the humeral head into the glenoid cavity. The supraspinatus, infraspinatus, teres minor, and subscapularis are the arrangement of rotator muscles for the shoulder. Now let's talk about ligaments. In the shoulder joint, the ligaments play a key role in stabilizing the bony structures. The majority of the ligaments are thickenings of the joint capsule. There are three kinds of glenohumeral ligaments: superior, middle, and inferior. Let's begin with the superior glenohumeral ligament. This limits external rotation and inferior translation of the humeral head. This ligament arises from the glenoid and inserts on the anatomical neck of the humerus. Let's move on to the middle glenohumeral ligament. This limits external rotation and anterior translation of the humeral head. This ligament arises from the glenoid and inserts on the anatomical neck of the humerus. Let's move on to the inferior glenohumeral ligament. This limits external rotation and superior and anterior translation of the humeral head, the anterior portion. It also limits internal rotation and anterior translation, the posterior portion of the humeral head. This ligament arises from the glenoid and inserts on the humerus just beyond the lesser tuberosity. Now, let's move on to two other types of ligaments. The coracohumeral ligament splits into anterior and posterior divisions by the biceps tendon. The anterior portion limits extension while the posterior portion limits flexion. Both divisions limit inferior and posterior translation of the humeral head. More importantly, this ligament helps to support the weight of the resting arm against gravity. It runs laterally from the coracoid process to the humerus, covering the superior glenohumeral ligament and blending with the superior joint capsule and supraspinatus tendon superiorly. Finally, let's talk about the transverse humeral ligament. This ligament serves to keep the tendon of the long head of the biceps in the bicipital groove. There is also another major ligament called the coracoacromial ligament. This one is special because, unlike the others, it is not a thickening of the joint capsule. It runs between the acromion and coracoid process of the scapula, forming the coracoacromial arch. This structure overlies the shoulder joint, preventing superior displacement of the humeral head. The glenohumeral joint has a wide range of movement, more than any other joint in the body. This is because it is a ball and socket joint. The shoulder allows for abduction, which is the elevation of the humerus on the glenoid in the frontal plane. The first 0 to 15 degrees of abduction is produced by the supraspinatus. The middle fibers of the deltoid are responsible for the next 15 to 90 degrees. Beyond 90 degrees, the scapula needs to be rotated in order to achieve abduction. This action is carried out by the trapezius and serratus anterior. Next, the glenohumeral joint is also able to perform flexion, which is the forward and upward movement of the humerus on the glenoid in the sagittal plane. This movement is produced by both heads of the biceps brachii, the pectoralis major, the anterior deltoid, and the coracobrachialis. Finally, another movement of the glenohumeral joint is extension. This is the upper movement of the humerus on the glenoid in the sagittal plane towards the rear of the body. This movement is produced by the posterior deltoid, the latissimus dorsi, and the teres major. Now, let's discuss internal and medial rotation. This is rotation of the humerus on the glenoid in a medial direction. This action is produced by contraction of the subscapularis, the pectoralis major, the latissimus dorsi, the teres major, and anterior deltoid. The next movement is the external and lateral rotation. This is rotation of the humerus on the glenoid in a lateral direction. It is produced by contraction of the infraspinatus and teres minor. Now, let's move on to scapular plane abduction. This is elevation of the humerus on the glenoid in the scapular plane, which is midway between the coronal and sagittal planes. Furthermore, let's talk about horizontal adduction. This is movement of the humerus on the glenoid in a medial direction, usually accompanied with some degree of shoulder flexion. Finally, let's talk about adduction. This is when the upper limb moves towards the midline in the coronal plane. It is produced by the contraction of the pectoralis major, the latissimus dorsi, and teres major. Now, let's discuss injury. One common injury that occurs at the shoulder joint is dislocation. Clinically, dislocations at the shoulder are described by where the humeral head lies in relation to the infraglenoid tubercle. Anterior dislocations are the most prevalent, although posterior dislocations can sometimes occur. Superior movement of the humeral head is prevented by the coracoacromial arch. An anterior dislocation is usually caused by excessive extension and lateral rotation of the humerus. The humeral head is forced anteriorly and inferiorly into the weakest part of the joint capsule. Tearing of the joint capsule is associated with an increased risk of future dislocations. The axillary nerve runs in close proximity to the shoulder joint and can be damaged in the dislocation. Injury to the axillary nerve causes paralysis of the deltoid and loss of sensation over regimental badge area. A dislocation can also stretch the radial nerve as it is tightly bound in the radial groove. Another common glenohumeral injury is rotator cuff tendinitis. The rotator cuff muscles have a very important role in stabilizing the glenohumeral joint. They are often under heavy strain, and therefore injuries of these muscles are relatively common. Tendinitis refers to inflammation of the muscle tendons, usually due to overuse. Over time, this causes degenerative changes in the subacromial bursa and the supraspinatus tendon. This increases friction between the structures of the joint. The characteristic sign of rotator cuff tendinitis is the painful arc, pain in the middle of abduction where the affected area comes into contact with the acromion. This condition usually occurs over time. It can be the result of keeping your shoulder in one position for a while, sleeping on your shoulder every night, or participating in activities that require lifting your arm over your head, such as pitching. Athletes playing sports that require lifting their arm over their head commonly develop rotator cuff tendinitis. This is why the condition may also be referred to as swimmer's shoulder, pitcher's shoulder, or tennis shoulder. Sometimes rotator cuff tendinitis can occur without any known cause. Most people with rotator cuff tendinitis are able to regain full function of the shoulder without any pain. Let's talk about rotator cuff tendinitis in the context of a medical journal and published article. In the article Functional Anatomy of the Shoulder, authored by Glenn C. Terry, medical doctor, Thomas M. Chop, medical doctor, from the Houston Clinic in Columbus, Georgia, we are presented with a very thorough overview of the shoulder anatomy and its function. This article is taken from the Journal of Athletic Training and states that shoulder motion is the result of the complex interplay of static and dynamic stabilizers. The bony anatomy provides the structural foundation from which the forces are generated and subsequently acted on. Regarding the glenohumeral joint, the capsulo-ligamentous complex provides static restraint, while the rotator cuff muscles, along with their respective force couple antagonists, guide, steer, and maintain the head dynamically in the glenoid fossa. Glenohumeral injury and instability can result when one or more of the bony, static, or dynamic components of this interaction are disrupted. Only when all the components contributing to shoulder motion are returned to their fully functional state can the athlete perform to the highest expectations. A thorough knowledge of the functional anatomy of the shoulder joint allows the medical provider to take a sound approach in the evaluation and management of the athlete's shoulder. The highest number of shoulder injuries occur in postmenopausal women due to a hormonal link. Now let's talk about bursae. Multiple bursae are distributed throughout the shoulder complex. However, the subacromial bursa is one of the largest bursae in the body. The subacromial bursa is composed of the subdeltoid and subacromial bursa because they are often continuous. This bursa serves to allow the rotator cuff to slide easily beneath the deltoid muscle. The most common problem is shoulder bursitis. Now let's talk about some fun facts. For healthy patients, shoulder dislocations heal within 12 weeks of the injury. Also, did you know that touching someone's arm or shoulder while asking them out increases the chances of them saying yes, according to lead psychologists?